Cool. Good evening, guys. So today's session is more urology, a bit of pediatrics, a bit of gynae. We're going to have some good interactivity. Sorry you can't actually see me, but I am excited for this. So let's get going. And apologies for like my immature plant photos, but I couldn't resist when I saw this on Twitter. So a 24-year-old male comes to see you in general practice with a 5-day history of scrotal pain. He also reports dysuria. On examination, there is swelling and increased temperature of the right testis with relief on pain when it's elevated. Given the most likely diagnosis, which of the following tests is most likely to yield the etiology for this condition? So we've got urine, MCNS, blood cultures, surgical exploration, ultrasound of testes, and first catch NAT testing. And yeah, it's just going to be a pop it in the chat box function, I think. Okay, so we've got one for D, one for E. Anyone else want to give their opinion? Okay, so we've got a bit of a split. So what do we think is the kind of unifying diagnosis here? Because I feel like all of you have made, like, they're all good suggestions. There's one that's kind of the best answer, but you're all like on the right lines and none of you have said C, so I think you're safe. Yeah, so we're thinking epididymitis. This has been, like a slightly sort of subacute presentation, and there's some dysuria as well. So Roger, you're on the right lines of like you might do an ultrasound to rule out just to make sure like there's definitely not a torsion. Apart from maybe some inflammation, I don't know if you'd see too much on ultrasound. And then Miriam, you've gone for urinary MCNS, which is a really good shout for this condition in elderly people because they get retrograde flow of urine and can have kind of E. coli infections causing it. But the person who's kind of got the money is Rajashri with first cat NAT testing, because the most likely etiology in this, usually in this age group, is an STI. So yeah, so the main one I think to remember, and it's based on age groups, the most common is E. coli, and that's just because of retrograde flow of urine. And then you're usually thinking STI is chlamydia, gonorrhea, and then there's a few kind of slightly rarer causes, but ones that I don't think we really need to focus on. Okay, so this gentleman has his NAT testing. It comes back positive for both chlamydia and gonorrhea. He doesn't have any drug allergies. What is the first line treatment for him? So we've got intramuscular doxycycline and oral ceftriaxone, and oral azithromycin, oral ciprofloxacin and oral azithromycin, IM ceftriaxone and oral doxycycline, IM doxycycline and oral ciprofloxacin. I felt like that was a genuine tongue twister, to be honest, to get through. I would say that the antibiotics for STIs are very high yield questions. They're definitely worth looking over before the exams. Okay, so we've got one for D from Patrick. Who else wants to go? And we've got one for E and D. Good. So we've got a bit of a split. I didn't obviously throw in like a pen allergy or anything like that. And so we'll go through it. So honestly, once you do your STI stuff and once you cover that, like you'll have a basis for it. I think I want to say that Divya and Mark covered it in a previous session, so go back and watch that if you want some extra stuff on it. But the main one you're going to do, so the intramuscular ceftriaxone is for gonorrhea, and that's like a one-off dose. And then oral doxycycline covers you for the chlamydia, and I think that's typically like 10 days. So ciprofloxacin is a really good shout if you had an elderly gentleman with an E. coli infection, because that's got really good cover. And then as oral azithromycin is a good option for either of them, but it's usually kind of a second line thing that they would use if someone didn't want an intramuscular injection, or there was maybe a pen allergy or something. But usually, like, those are your two go-tos. And I guess I just was trying to test your knowledge of like which routes for which, so those are worth knowing as well. Perfect. So can anyone give me any examples of other causes of scrotal pain or testicular pain? Like, what are our other kind of big ones in urology? So yeah, massive one is testicular torsion. We want to rule that out. Do we know kind of at what point, if torsion occurs, that you'll get necrosis of the testis and you might lose it? What's kind of the ballpark timing in exams? So yeah, I think 6 hours is kind of the max, but yeah, it can occur quicker. So yeah, around that time. So for those patients, like, you want them in urgently. Can we think of any other things that might cause pain that are not so acutely stressful? So we mentioned epididymitis, and what can cause, like, what sort of another bit that can become an itis? So we'll come on to varicocele, but they're not typically causing pain. There's another seal that causes pain, but it's not varicocele typically. Yep, so orchitis, so yeah, inflammation of the testis itself. Fantastic. So it's all right. So the main other one we might be thinking about is a hydrocele, and then you've got your classic things like, sorry, and my handwriting is abysmal, but I quite like this feature for a pencil. So trauma, so like, schoolboy stuff, like that can cause a lot of pain. Hydroceles, so we'll go through that in a second. Torsion is our big one that we want to rule out off the bat. You can get referred pain to the testicles. So, for example, in patients who've got ureteric stones and things like that, they can get shooting pain that goes there as well. There's also hernia, like direct hernias can cause pain as well by going that way. So just bear those in mind as well. And then generally, like, inflammation of the testis is the other big one, and spermatoceles, which occur usually after operations. Cool. So a young male presents with a 4-hour history of extremely painful left testicle. On examination, the pain is not relieving when you elevate it, which is, does anyone know like what that sign is called when you see if elevation of the testis causes them to have some relief? Does anyone know what that's called? It's worth knowing for urology. Yes, that's Prensine. Fantastic, guys. So if by elevation it's relieved, we're thinking epididymitis. If it doesn't relieve, we're thinking this pathology, which, like, I'm sure you've all guessed at this point. So he's Prensine negative, he's sweaty, he's distressed. What is the most appropriate next step in management? So we've got an urgent testicular ultrasound, urgent urethral NAT testing, urgent surgical exploration, urine. Don't know why I wrote that. I think I meant urgent, but I wrote urine. Urgent CT pelvis, urgent angiogram with IR intervention. So we got one for C. Everyone agree? Yeah, Miriam, you're on the money. Yeah, so testicular torsion, you call urology, they're going straight to theatre. Fantastic. Because the necrosis can occur in 6 hours. And I think especially in this question, like, they're already at the 4-hour mark. By the time that you get the anaesthetist, you call urology, they come back from their tea break, like, it's probably time to open under the testis. to be honest, and sort it out. And typically they'll fix, if one side is torted, they'll fix the other one, because if you kind of got the anatomy to do it on one side, you might get it on the other. And you obviously, if any kind of compromises happen to that testicle, you want to preserve some fertility afterwards. So you want to make sure that the normal one is happy as Larry. Cool. Onwards and upwards. So I mentioned varicoceles. Does anyone know what a varicocele is? Could anyone sort of give a description of it? Can be as colloquial as you want. And does anyone also know what a hydrocele is? And don't worry, like none of these slides contain actual penis photos, so we're okay. I sort of replace them with plants because I prefer plants. So yeah, hydroceles. So they are like clear fluid. They transilluminate, and it's this fluid that basically will go into it that accumulates like in the tunica vaginalis. And then the varicocele is like the dilated veins in the testis. So it's basically like varicose veins of the testis. What do you think a problem could be if you've got a male that's kind of got basically warm blood in these dilated veins surrounding the testis? What's like the main problem they could get? Yeah, so subfertility. So sperm want to be at a lower temperature. That's kind of why the testes are outside of the body. And so if you've got warm blood there, you can get this subfertility basically. Cool. So this is a hydrocele on ultrasound. So it's like very uniform and like fluid is there. And then this is my kind of varicocele bag of worms picture, because I didn't want to put an actual picture. So a hydrocele is this collection of peritoneal fluid, which is in the tunica vaginalis, and it surrounds the testes and the spermatic cord. It can cause pain, and this is one of the differentiators. So it can transilluminate, a varicocele won't, and it can also be painful, and that's a typical reason that you would do management for this. A lot of men can have these and be asymptomatic, and you might just leave them, but if you're getting a pressure and a pain from that, you're going to sort it out. Cool. And then a varicocele, so it's the pampiniform plexus veins, and the majority on the left-hand side because of the way things drain, and we'll go into that in a second. And generally, like a varicocele is bad news for fertility. There are men that still conceive, and it's not an absolute, but we see that they make up 40% of men who are who have infertility or subfertility. And especially if they're young and they have bilateral varicoceles, you're going to want to do surgical management because it can affect the development of the testes, the maturation, and the sperm count. So that's like another indication. Cool. So you have a 17-year-old male patient who has a left-sided varicocele. Which of these additional tests is indicated for this patient? So we've got ultrasound abdominal vasculature, ultrasound left kidney, semen analysis, CT chest abdo-pelvis, and testicular biopsy. So yep, we've got some answers for B, which is the correct answer. So we'll go on to why that is. So basically, because of the drainage to the the drainage of the testes is quite important. The right side can go all the way up straight into the inferior vena cava, and that blood goes elsewhere. But if there's the problem with the left side typically drains through the left renal vein and then into the IVC, because it's kind of on the left side, it's got to get over. And so if you've got any pathology of the kidney, which obstructs or disrupts the venous drainage, it's all going to just back up, and might present with a varicocele. So if you've got someone who's at the right age and has a left-sided varicocele and has weight loss, night sweats, that kind of thing, or a loin mass, you might be thinking about renal cell carcinoma. And so that's something to bear in mind. That's kind of the main red flag issue that can happen with varicoceles. So yeah, fantastic, cool. So slightly changing piece to smidge. So this comes up a little bit with gum. So which urological procedure has been found to reduce the risk of acquiring HIV in men? Straight in there. So yeah, Lubna, you're absolutely right. So it's circumcision. So that's something just to bear in mind, that obviously you'd still, doesn't mean like you won't get HIV, but they found with populations that circumcision reduces the risk, and they think that's because of like you don't get the micro tears and things. Cool. So which of the following is not an indication for a circumcision? So recurrent balanitis, hypospadias, paraphimosis, religious practices, and Peyronie's disease. So I've stepped it up. I've been a bit meaner because these are all the technical terms for things. And this, if anyone is wondering like what she's doing with her life, this is called colloquially called a penis plant, and it's a type of plant that like rarely flowers, but when it flowers, the flowers smell absolutely vile. And so this was in like the news the other day that it famously flowered at one of the big botanical gardens, and caused people went to go see how awful it smelled. But anyway, back to the question, not my sad existence. So which of the following is not an indication? What do we reckon? Okay, so we've got one for B, one for E. What does everyone else think? We've got one for D. Interesting. Okay, so I've been a bit mean. Like I didn't write medical. I'd written like medical indication. Then I guess like religious practices wouldn't come under it. But like in life, most circumcisions are done because of in certain religions. So like in Jewish people and Muslim people, it's very common. So if we take that one out, because if that kind of threw people, I just couldn't really think of another answer. But we take that out and we're left with the other four. Does anyone want to revise their answers for the people that put D? So recurrent balanitis is basically inflammation of the top of the penis. And then hypospadias are where you get the urethral opening is not at the correct point. It's not at the end of the penis. It can be like on the shaft or elsewhere. Paraphimosis is like a fibrous constriction of the foreskin. And then Peyronie's is like they get a plaque on one side of the penis that can cause distortion to the shape of the penis. Okay, so we've then got hypospadia and Peyronie seems to be the kind of general theme. So I think that's really good. So one of those is right, and the one that is the wrong answer in this case is Peyronie's. And so in recurrent balanitis, it's usually that they're getting that because the foreskin's too tight and it needs relieving. So that is one of the indications. Paraphimosis, they're born with too tight a foreskin and it needs removal. So that's also correct. And then with hypospadias, they end up having a circumcision because when you've got the urethral opening, let's say on the shaft of the penis, they can use the skin of the foreskin to basically close off that hole and then correct it and make the proper opening. And so typically when tiny babies will go for circumcision or children, they'll make absolutely sure that there's not a hypospadia, because if there is, then you would use that the skin to fix it basically. And then Peyronie is because it's this distortion of the shaft of the penis. Typically it involves different surgical techniques, which I don't think you have to be too familiar about, but it's not really affecting the top of the penis, it's more of the shaft. So they do other corrections with the scar tissue basically. Cool. So circumcision. It's just worth knowing that those are the medical indications, and I've popped the thing about hypospadias as well. And then, yep, so the benefits: reduces the risk of penile cancer, reduces the risk of UTI, and it reduces the risk of STIs such as HIV. That doesn't mean everyone has to have one. Most people are fine, but yeah, those are just some of the benefits. And obviously, penile cancer is very rare anyway, so you're reducing the risk of something that's already quite low. Okay, so 2 patients present to A&E with painful testes and facial swellings. Which of the following is false regarding the most likely etiology? And if any of you are Brooklyn Nine-Nine fans like me, you'll know the etiology if you've seen this episode. So, A, it's a notifiable disease. B, it's a paramyxovirus. C, peak incidence is winter to spring. D, it is most contagious after onset of symptoms. And E, parotitis is the most common manifestation. I'm genuinely like, I'm pushing you guys because this is like, we might as well. So yeah, we've got 1 for D. Anyone else? We've got some more for D. So yeah, it's D. Fantastic. So for anyone who didn't see the episode, it's worth watching. Actually, it's very funny. So this is mumps, is what we're going for, because we've got bilateral facial swelling and testicular swelling. And so it's a notifiable disease. It's a paramyxovirus. It typically occurs in winter and spring, which is kind of classic for any infection. I'll go into this, but it's most contagious actually 2 days before symptoms start. So that means it just used to spread like wildfire. And then parotid swelling is like the most common symptom. Cool, perfect. So kids can genuinely look like this, very miserable, very large parotid glands, and like they can almost merges like their face to their chin. It can be so big. And so it's got the classic viral prodrome, and then you develop the parotitis. The incubation period is about 5 days. And then, so the most common is parotitis, and then it's orchitis. There's some evidence to show that there's like testicular atrophy that can occur with it, but generally, like males don't often get sterile, but that is always a risk. If you have enough people, like this can happen. And oddly enough, like in females, there is some ovarian inflammation, but it's not as prevalent as with orchitis. Cool. And then it can cause funky neurological stuff, but you don't need to know it. But just in case you do, it can cause things like that. Cool. So you want to test this guy for mumps. Which test do you use? I feel like a lot of sexual health is like knowing which test to do. So yeah, just don't worry about being wrong. Just pick one and we can go through it. I used to find I always remembered stuff if I was wrong originally. Cool. So we've got 1 for A. Very reasonable. It's a virus, and there's often we do PCR, so it's not that one. Lubnar has gone for B, which and Roja has 2, which is actually the right answer. So for mumps, we typically go for IgM serology. So if you just remember that, which is never really a good shout with viruses as like a rule. So usually like you can discount that. And you probably like wouldn't really do sputum per se. Like it'd be like saliva you would do because it's the parotitis. And then like blood cultures just seems a bit extreme. So if you were kind of going to eliminate those, and then you're looking for acute infection, and so you pick IgM antibodies over IgG because that would be like a chronic picture. So just sometimes, like, even if you don't know, you can sort of rule stuff out and then do I do and pick the wrong answer of the two. Cool. So management of mumps. Does anyone know what we would do with patients? So viral PCR, I think maybe the antibodies are just far more sensitive, is what I reckon. I haven't like looked it up per se, but probably it's most likely that probably the virus is gone, and then you get the antibodies for a longer length of time afterwards. So that might be why you do it rather than PCR, because for a lot of other things you'll do PCR. It's probably kind of similar with some other conditions where you'll do like the antibody and you'll do the PCR, because it might be either or rather than both. So what do we do for mumps? Or what can we do? Do we excise their carotids bilaterally and leave them with no saliva production and horrendous disfigurement? No. So yeah, supportive management. So supportive management usually self-resolves, and you can use cold compresses for the testes. So in that episode, they're sort of sitting there with frozen peas. There's no real benefit of steroids or anything of that, and I think they've tried surgical drainage in the past and it hasn't been beneficial. Immunoglobulins aren't beneficial, and the general thing is like you're going to want to vaccinate if they haven't been vaccinated, or any of their contacts who haven't been vaccinated, and generally like the immunity is fantastic, and the resurgence we're getting in mumps is mostly in unvaccinated populations. And then I just wanted to point out that like the MMR vaccine is a live vaccine, and these are all the other ones. And I think I touched on this when I did some varicella teaching. Who can't we give live vaccines to? Because this is like always a question. What scenarios would we not give a live vaccine? So yeah, pregnancy. So fantastic if you had a pregnant woman who's been in contact with a child with mumps, hasn't been vaccinated, you can't give the vaccine. Immunocompromised, yep. So cancer patients, chemotherapy patients, HIV, fantastic. And then who might we, what kind of drugs for like rheumatological conditions might we avoid this in, or like absolutely have to avoid it in? Because they might give that in the vignette of like, you know, a rheumatoid arthritis patient is started on this drug. So yep, anti-TNF can definitely do it. That can reduce, you know, immunocompromise them enough. And then other DMARDs, so like methotrexate, that kind of thing. So it's worth just scanning the drugs, and especially you might get this in the PSA next year. It might be worth just being aware. So yeah, fantastic, guys. Cool. So a female patient comes to see you with her partner. You're having a very busy clinic, it seems, with like a variety of things. So female patient comes to see you with her partner. They have completed their family and don't wish to have any more children. You outline their contraceptive and surgical options. So they're, you know, kind of looking for a more sort of permanent solution. So which of the following statements is false? Post vasectomy, 2 semen samples are required to confirm infertility. Vasectomy is less effective than female sterilization. Vasectomy is potentially reversible. Vasectomy is usually conducted under local anesthetic. Female sterilization has a low likelihood of successful reversibility. So we've got 1 for B, 1 for C. Another B. Cool. So the answer is B. I was wondering with C, I think it seems a bit low actually, because often it's kind of shown as like, I think the common thing is like people think, oh, vasectomy, like 100%, like you can reverse it really easily. It's about 50%. So that is something to counsel patients on. But yeah, so basically vasectomy is more effective than female sterilization. It's also like less invasive. It can be done under local, whereas like clipping the tubes is, a GA operation. And so actually sometimes it's better for like the male to do it rather than the female. But obviously you'd sort of take their preferences into account. Post vasectomy, it's not immediate infertility, so you need to counsel them on that. But generally, like they can go home after a couple of hours. A few men might get post vasectomy pain, that kind of thing. And the usual kind of surgical complications, infection, hematoma, that kind of thing. But overall, like it's a very safe operation, and it is much more reversible than the like female sterilization, which is a lot less reversible. Cool. So we're going on to Urogyny. This is paintings by George O'Keeffe, in case anyone is a budding art lover. So let's fill in some gaps, because I thought let's just have a break from the SBA format for a sec. So a 23-year-old female of that many weeks gestation is found to have asymptomatic pyuria. The most suitable first-line management is, and then actually I'll just let you guys read it, and then I think if you just put in your answers or even just write them down if you don't want to share, like that's fine. And then let's see like what the answers are. And these are quite sort of classic questions that you'll get in the kind of gynae sections of your paper. Okay, so Jordan's gone for 7 days, trimethoprim, and then nitrofurantoin. So you're correct, Jordan. Do you want to just explain your reasoning of why you're doing, like what the main risks are if you did it the other way around? And yeah, generally for UTIs in pregnant women, it's 7 days, and it's whether they're asymptomatic or not. You treat the underlying infection. So yeah, we've got 3 for clotrimazole pessary, which is correct. So oral antifungals contraindicated in pregnancy, but you can do a pessary. And usually symptomatic thrush is treated because it's associated with like premature labor. And generally for these, so you're going to avoid nitrofurantoin in the 3rd trimester because it's associated with premature birth again. And then trimethoprim absolutely not in the 1st trimester because it's antifolate, and so you could cause anencephaly, you could cause spina bifida. And then so Miriam, you're correct. So in a woman who's postmenopausal, from guessing from the age, and she's presenting with dryness and painful sex, topical estrogen is like now becoming much more recognized as something that a lot of more women should have access to. It doesn't have the concerns over carcinogenesis are a lot lower than anticipated. And then just simple things like lubricants as well can be very useful for women. And yeah, so nitrofurantoin you would avoid in G6PD as well. And there's like a whole bunch of drugs for G6PD. It doesn't come up so much in 5th year as a thing, but generally the broad groups are like antimalarials, certain antibiotics such as nitrofurantoin and dapsone, and some analgesias and sulfur drugs as well for like those groups. But I don't anticipate for UCL 5th year exams that they would test you on that, but it's just worth knowing and being aware of it. Cool. So there are our gaps. Cool. And yep, so the final thing for this lady might be that you might consider HRT if she's got some other symptoms as well. So we're just going to touch a bit on HRT. So the 58-year-old female patient would like to discuss options for systemic HRT therapy because of symptoms she's been having. So what are the important questions to ask when considering HRT prescribing? What do we want to know? What extra info? So yep, so family history of cancers, past medical history of breast cancer, ovarian cancer, yep. So anything estrogen dependent cancer-wise we want to know. Age at menopause. So yeah, we'd want to know sort of how far into the menopause she is, because it's this kind of perimenopausal period that you have the most symptoms, and then things become a bit more static and recover, and they can get the residual problems like dryness and that kind of stuff, which you'd maybe treat a bit more differently than doing systemic. DVT risk factors, yep. So we're giving hormones, and so that can increase the risk. Does she have a womb? Fantastic, because that lets us know if we're going to use progesterone or not. Smoking, yep, because of VTE risk. BMI, because of VTE risk and cancer risk as well. So yeah, these are all really good questions. So it's good to ask her what her prominent menopausal symptoms are, because it lets you, because for some women, they put other things down to the menopause, and they'll say like, oh, I was just told this was normal for my age, and actually they can have another pathology, so it's worth not like having tunnel vision. But generally, like the main things would be like the hot flushes, the dryness, the irritability, low mood, sleep changes. And then we want to know whether she's still having occasional periods or she's stopped having periods, because that tells us we want to do a continuous or a combined therapy. And then does she have any like contraindications, basically, which we'll go through in a second. And does she still have a uterus? Because you cannot give unopposed estrogen to a woman with a uterus, because the development of endometrial cancer is usually estrogen dependent, and we know that progesterone protects against endometrial cancer. Cool. So I'm not going to like go through all of these, because I think generally it's something you can look at for yourself. But I think like the main themes from the NICE guidance, which I have here, and so it saves you kind of like trudging through all that. But generally, like, do they have current cancer? Do they have past cancer that would make you avoid this? The VTE risk is a thing to think about, but it doesn't deter from all types of HRT. Have they had recent thromboembolic events such as a MI or a stroke that would make you hesitate to do this? You can't give it an active liver disease because of the metabolism of estrogens gets decreased, and so whatever you're giving is almost an overdose, essentially. And then the relative contraindications are kind of these ones. To be honest, in practice, so just because like we covered it in my women's health BSc, a lot of this data is quite historic, that kind of guided all of these things. And so in practice, very specialist people may sort of decide with some nuance whether to give HRT to a woman who's categorically at risk. But for us, these are the contraindications, these are the relative ones. And so if you were going to take a really thorough gynae history for menopausal stuff, you're kind of having these in your mind. Cool. So our lady has a history of a DVT 15 years ago. She has had a hysterectomy in the past, and her last period was 2 years ago. Her main menopausal symptoms are low mood and hot flushes. Which of the following is most suitable for her? Continuous oral estrogen and progesterone, continuous oral estrogen only, transdermal estrogen only, sertraline, and cyclical oral estrogen. So Jordan's gone for C. Any other takers? So yep, another C. And I think if you've not covered HRT, like it can seem a bit overwhelming, but generally it's quite simple when you read up on it. So the correct answer is C, basically. But so Roger's put D, and that is also something that you could think about. And I think it would be between these two answers. So she's had a DVT. So off the bat, we're thinking contraindicated. She can't have it. But she's very symptomatic, and you could be convinced that, this was 15 years ago, and maybe I could have written in that it was like a very provoked DVT or something. But actually the transdermal preparations have a much lower VTE risk. So they are an option for her. And so she doesn't need, and none of you put anything with progesterone in because you picked up that she's had a hysterectomy, so we don't need to cover for that. She's not had periods for 2 years, so she doesn't need cyclical. She doesn't need it to mimic any of that stuff. Sertraline. So SSRIs are kind of the line which you do if they are absolutely, if you had a previous breast cancer patient, but actually HRT has been found to be more beneficial for the mood in these cases than SSRIs. Is there a cutoff? I doubt it, to be honest. I think I might need to get back to you on like whether there is a cutoff for DVT. On the NICE CKS, it just says like previous DVT. I reckon there's probably some nuance depending on the specialist, but I think the main thing is if you've got a woman with a history of DVT, you're thinking, can I give transdermal? Will that work? That's probably a possibility, but you're definitely not going to give like oral, because that can increase the risk. And there's also kind of lower dose preparations as well that you could give. But I don't think there's an exact cutoff. I just kind of put that in because I didn't want to throw you guys by saying like she had a DVT a year ago and then everyone would get a bit nervous. It's kind of a bit more clear cut of like it was quite historic. And she's not had like recurrent DVTs and has antiphospholipid syndrome and you're really, really concerned. This is kind of just one that she had a few years ago. Cool. Okay, so we're on to the picture round for the last 10 minutes. So we have got some, let me just check that my animations definitely work. Fantastic. So we had mumps, so we're now going to have some other neck lumps. So you see this, and it's a bit of a pediatric theme this evening. So you've got this little boy, and he's got a fluctuant mass around here. What are we thinking? Jess is straight in there, branchial cyst. So yeah, good. Yeah, perfect. Branchial cyst. So if it's on the side, fluctuant, you're thinking branchial cyst. And these are the most common congenital neck lumps. They are non-tender, fluctuant. They may grow with illness, so that if they have an upper respiratory tract infection, they might get bigger. And if they are becoming symptomatic and irritating and unsightly, then you can do a complete excision when they're not infectious, but otherwise it's quite conservative. A lot of the population have them, so they're not typically, they're small, you just leave them. Perfect. Okay, so then we've got two babies who have these. Does anyone know what this is? So yeah, this is a cystic hygroma. So Burkitt's could be another shout. I think because they're so little, and usually with a cystic hygroma, I didn't give you a vignette, but typically it would be like they're born with it or it like comes up in the over the first 2 years of life. Whereas a Burkitt would be a bit more likely to be kind of a slightly older child, over 5. And that goes with like endemic EBV, but that's still a good shout because they can cause really cracking massive neck lumps. So do we worry about cystic hygromas, Jordan? I'll not like pick on you massively. Are there any problems with them? It's kind of a leading question, really. Yeah, so if that baby's got that there, it's not really going to help, is it, with the breathing? So yeah, they can cause airway compromise, and so they do much more kind of ruthless management of these. So I think they actually excise them, because I think if you drain them, they just refill, but they might also drain. So it's the most common type of lymphangioma, and it's basically just a congenital malformation of the lymphatics, and so this will be full of lymph fluid. Usually in the cervical regions, they can also be in the armpits. They are associated with aneuploidies, so like Edwards syndrome, Patel syndrome, that kind of thing. And so there's an increased risk of like intrauterine death, but that might just be the contributing aneuploidy as well. So if you get a cystic hygroma, you've also got to think about genetic abnormalities. Cool. So on to the next one. So this is Jimmy, and he's got this fluctuant neck lump. What might be some other features you would look for, given the most likely diagnosis? So yeah, this is a thyroglossal cyst. So like, what might you know on examination with a thyroglossal cyst? Yep. So it moves up and down with tongue protrusion. Good. Fantastic. And where does the thyroid originate from? Does anyone remember this? Because the thyroid goes on a bit of a journey in embryology, and so these can go anywhere along that trajectory. So yeah, back of the tongue, so there's like that little depression, back of the tongue. Fantastic. So this is like the most common congenital cervical anomaly, like anomaly in general. It can form anywhere across the thyroid's migration, so anywhere from the sort of tongue up here down. It's usually midline, mobile, movement with swallowing, and tongue protrusion, and it's closely associated with the hyoid bone. You could probably get infection in there, you can get inflammation in there. The management is usually excision, but the recurrence is quite high. So something to be aware of. Right, bit of a stretch one. This isn't the most common thing we would see here. You might see it more commonly in other parts of the world. So this is, I'll give you a bit. So this is a child that presents with this, what looks like an incredibly angry swelling with some kind of slight discharge, but the child is in no pain, like at all. And I would say that for this country, they'd be more likely having migrated from somewhere with like a greater prevalence of this disease. So it's painless, it's purulent, but it's cold. So it's not hot to touch, even though it looks like it should be hot to touch. And once these recover, they can be they can scar. So this is caused by like a certain infective disease. So yeah, Nivitha TB is the correct answer. Do you know what this is called? Does anyone know what the name for this is? So it's basically like an inflamed TB lymph node. I'm sort of prepping you for like final stretch question, maybe. So it's not Gons, that's basically like the primary lesion in the lung. So yeah, it's scrofula. Fantastic, well done. So yeah, so this is basically like the inflamed lymph node and TB. TB is the most common thing, but in children they can get this other form from another type of mycobacterium. And yeah, it's this cold abscess is the classic thing that you get with TB. So it's an abscess, which is just like there's no increased temperature. And they might be like a bit systemically unwell. So yeah, fantastic. So because I've done eyes a bit this year, so this is you do some fundoscopy and you see these appearances in a young child. So we don't know the underlying reason they could have this. If you think back to my lecture, like kind of the few lectures I've done, what do we think all of these are? Kind of cruising around. If we ignore this like horrendous thing in the middle, what do we think all these are? So yeah, bleeding. And how would you call that if you were in an exam and you said you know there's bleeding? What would be the kind of thing that you might say? So it's of the retina, so we might call it something specific. So yeah, retinal hemorrhages. So you've got a child with retinal hemorrhages. What is the thing that you're most worried about? And I've realised this is going to be a slightly depressing end to a lecture, which was not my intention, but I just thought we'll go over it. So yeah, shaken baby syndrome and like non-accidental injury. Or you're thinking like a very high impact injury, like a motor, like a motor vehicle accident or something. But like, let's go for non-accidental. What are the other features of like shaken baby syndrome? There's a triad. So yeah, subdural hematoma. And yeah, encephalopathy or brain swelling. So yeah, so like those are the features. And the stuff with about non-accidental injury is worth knowing because it makes you a safe clinician, and obviously it's something that they are on sort of red alert for in pediatrics. For pediatrics, there's kind of certain criteria for immediate CT heads. Does anyone know any of the kind of other things that might warrant an immediate CT head in a child? Because obviously they're not wanting to give unnecessary radiation, but at the same time, if you're worried enough, you'll do one. And so we've already touched on shaken baby. So like if you're thinking that there's been like a non-accidental injury, that'll do it. Yeah, so there's like certain number of episodes of vomiting that are kind of spaced out. Because that can indicate raised intracranial pressure. I think the thing is like when you get these in real life and in a question, they're just kind of common sense, like really worrying stuff where you'd be like, I need to get some imaging. So yeah, low GCS as well. So we'll go through them. So like a prolonged loss of consciousness, I guess concerning. Very long amnesia, they've not really got back to their baseline. They're abnormally drowsy. 3 or more discrete vomits. So it's not 2, it's 3. Clinical suspicion of non-accidental injury. There's some kind of seizure that's occurred secondary to trauma. A low GCS for a baby under 14, and this is sort of prolonged after the event. Suspicion of an open or depressed skull injury or a tense fontanelle indicating raised intracranial pressure. Evidence of a basal skull fracture, a focal neurological deficit, so they've got like a few cranial nerve abnormalities or something like that. And then a really dangerous mechanism of injury, so has this been like a really bad car accident or something? So what are some of the sites on the body that are suspicious for non-accidental injury? Because these might be the kind of distinguishing things in a question where you haven't got the patient in front of you, you're not seeing the whole picture, where you might think, I'm very worried. So yeah, fantastic. So it's anywhere that a child isn't going to fall. So they're going to fall, probably whack their head. So that's possibly an accident. They might hit their knees when they fall. They might hit their hips when they fall. But generally, ribs are always suspicious. Backs are always suspicious. Buttocks are always suspicious. Ears, backs of the ears, back of the head, long bones. So, yeah, so like, and yeah, fantastic. So you've covered them all. And so, yeah, ears. This is like a scalding injury. Like, how are they going to get scalded on a buttock? And like, sorry, I don't want to like upset anyone. I just thought let's just kind of go through with some pictures. And then this is from like one of the textbooks I have. It's also like marks. Certain marks are suspicious. So it's an upsetting thing to think about, but it is something to look at. Like, have they got a mark that maybe is in a, it's on the knee, but if it doesn't look like something like they've fallen over, instead it looks like a belt or something else, then you're worried as well. But generally, like, these are the things that you're worried about for non-accidental injury. Okay, so you see a child and they're found to have a fracture. So they've got a fracture of their tibia here. It's like a spiral. Is this non-accidental? And just in case it's like not, because it may not come up on people's screens, so there's like a spiral fracture this way, spiral fracture this way. So we've said like humerus and femur are very suspicious because they're, but is a tibia suspicious? So yeah, what I'm getting at is like this fracture is also called a toddler's fracture. Sorry, it's literally not doing it. So this isn't a non-accidental injury fracture. This is something that kids can commonly get between 9 months and 3 months. And it's just basically like a spiral fracture of the tibia. They're unable to weight bear with like a painful tibial diaphysis, and they just have a cast. So that might be a scenario that you might get. The other fractures to think about in children that are specific are things like green stick because of the plasticity of bone, and also buckle fractures because again, like so they just buckle their radius and things like that. So they're just the ones probably to revise from 4th year. Okay, so you have a adolescent who comes to see you, so it is 2 minutes past 7. We'll go till 10 past, if that's all right. We'll just get through the last couple. So these are more stretched as well from peds, but we'll just do them because it's good to get some, like, I think images for these ones rather than just like a written question. So you see a child who's got a lump on their distal, so that's distal fibula tibia, not tibula. It's got this appearance, and it's painful. It's more painful with activity. It's got this appearance, like what might be thinking of as like a broad etiology. So yeah, Jordan's straight in there. Sunburst pattern, yes, but not Ewing sarcoma. We'll come to Ewing sarcoma. So what's the other option? So yeah, it's osteosarcoma. So this is the sunburst appearance. And so with this, you can kind of, excuse my terrible drawing, but yeah, you're getting this kind of radiation here. And I think if you just look at a few photos of this, you'll get it. And so typically osteosarcoma is of the long bones, most commonly the femur. It can also be of the arms, that kind of thing. And yeah, Ewing's we're coming to, which is onion skin appearance. And so typically these children will present with bone pain that might wake them up at night, pain on activity, a limp, reduced range of motion, but they're not really going to have the systemic symptoms that would only occur with metastases. And with osteosarcoma, like it usually metastasizes a bit late. And the gold standard would be an MRI for like any cancer really. So that's that one. And then Ewing sarcoma is this onion skin appearance. So with sunburst, it was sort of radiating out almost, whereas with Ewing's, it's like multiple layers, like an onion, because onions have layers. And this is the second most common type of primary malignant tumor in children. Well, it's typically in children. It's very metastatic, so they might present more likely with systemic features of weight loss, that kind of thing. The prognosis for both of these has gotten a lot better with chemotherapies. Ewing's had a horrendous prognosis, but has gotten surprisingly better to over 70%, having 5-year survival. And this one can affect the pelvis, the axial skeleton, and the femur. Cool. Okay, I think we'll leave it there because, yeah, I think we'll leave it there. So I'll upload the slides because there's a few extra. I've just put in a few bits of info about hydroceles, epididymal cysts, that kind of thing. I hope that's been useful. If you have any more questions, I'm totally going to stick around. I'll just stop the recording. And just let me know in the feedback if you like this kind of mix at this point in the year. If there's anything you want to be covered in future. Anish will be back to do some lectures as well while the rest of us have finals. So yeah, but otherwise, like, have a really good evening. And you guys have been great and really interactive, so it's been great. And yeah, sorry for the technical glitches at the start.